for inviting me to moderate this academic webinar. As a president of ISSB AP chapter, I am happy to witness and support such meaningful academic initiatives by the Vizag City Branch. I also extend a warm welcome to all the participants who have joined us today. Today, we are honored to have with us Dr. Anand Murugesan, who will be delivering a talk on pulsed radio frequency, an important and relevant topic in interventional pain management. Dr. Anand Murugesan, sir, MD, FIPP, SIPS, is a senior consultant, anesthesiology and interventional pain management, Apollo Hospital, Chennai. His areas of interest, neuromodulation, joint denervation, MSK ultrasound and interventions, cancer pain interventions. His awards and publications, COPS Award by Indian Society of Anesthesiologists 2009, Young Pain Physician Award 2020, Apollo Hospitals, India, President, Musculoskeletal Ultrasound and Pain Society, Faculty, London Pain Forum, publications in PubMed Medical Indexed Journal, Chair in World Institute of Pain, India section. I am sure today's session will be highly informative and academically enriching for all of us. With great pleasure, I now invite Dr. Anand Murugesan to begin his presentation. Sir, over to you.
Thank you. That's very nice of you, sir. Thanks for your kind introduction. And I'm really overwhelmed and then privileged to take up this particular topic and as a speaker with ISSP City Branch of Vizag. So it was a really wonderful feel I had in Vizag when you had all taken care of me. So it was really a very nice hospitality. I enjoyed it. So let's keep having many such webinar sessions and enrich our knowledge, as you rightly said. So it's really a very good beginning, and it's in fact perhaps a very important topic to start with. So because there are many gray areas in pain, as Dr. Praveen rightly mentioned, I think he has a good clinical practice. So he really appreciate the importance of this particular topic and a lot of myths behind this topic about the pulsed. So let's break the myth and unfold the real opportunities in doing this particular intervention to benefit all our patients and to have a good clinical outcome. And what are all the areas where we can implement this particular technique and make our patients benefited out of it. So with this, let's get into the discussion of the topic as such, what I'm going to speak on. So I'm sharing the slide. So
it's already on, sir. You just keep it full screen and run the show.
Oh, it's already on.
Yes, sir.
Okay, I got it. Second, words I'm not getting from me. Textile industry, printing factories, and ceramic producers. Can you see the full screen now?
Yes, sir.
Yes, sir. Able to see.
Fine. Okay, so thank you so much for the opportunity. So we are going to have a brief 30 minutes talk on what is pulse radio frequency ablation and what can you hear me?
Yes, sir.
So, and what are all its principles, and how is it useful in our clinical practice? So, this is generally about the radio frequency circuit. So, we are having these four components. The radio frequency generator, which is the source of the current we give. It's an alternative current of high frequency and high voltage. And then that is passing on to an electrode that goes into the patient through a cannula with an active tip on the tissues. And we have a thermistor to measure the temperature that is shown on the monitor of the RF ablate or whatever the temperature you choose. So that is measured at the tissue level. And obviously, whatever current you give should come back. So it is always, it's a circuit. The patient is going to be a part of the circuit. So it's a closed circuit, and patient is actually a part of the circuit where you generate current and pass on the current to an electrode, which has got an active tip, which is going into the tissues. So from there, it goes to the tissues of the patient, and the temperature is generated there. And the generated temperature is measured by the same the probe, and that is sent to the machine, which is shown in the valve in the digit as the temperature, and the return current will be grounded with our grounding pad. So this is basically a four component circuit where the patient is actually a part of the circuit. So as I mentioned, a generator produces a high frequency alternate current. You all would have seen the generator. It's a big console, like which is connected to a plug point. And once you plug it, it generates an alternating current. And that current, and you have got the probes that is connected to the generator, and that electrical cable is connected to the probe. And the needle has got an active tip, and the probe goes into the needle. So this generator produces the high frequency current, and it will pass on to the active electrode. The second component is an electrode. So this electrode is placed onto the patient. So that is it has got a working end. You have got the multiple measurements, 5 millimeters, 10 millimeters, 15 millimeters. You have to choose the cannula based on the need. How deep the target is going to be, and whether you need a long tape or a short tape. So why you need a short tape, active tape, why you need a long tape. So we are going to discuss on that, because the lesion characteristics varies with the active tip length. So basically the active tip is the one, the electric current goes, and it is placed on the tissues. Then the thermistor and thermocouple is actually the one which measures the temperature, and then it gives back that signal to the machine, and the machine will tell us what is the heat at the level at the tissues. And the passive electrode, of course, has to complete the whatever heat you give. It has to return back, and then it has to be grounded in the skin. And why we are going to keep the passive electrode? This is something really very important, because the grounding pad, what it does actually is the active tip will concentrate the heat at the tissue level, and that much of tissue is propagating in the tissues, and it has to return back. So when you don't keep the passive electrode or a grounding pad, there will be an exit. It's like an electrocution. You get an electrocution, you got an entry wound and an exit wound. You all know that. So how safely you have to ground that heat is what is very important. So that's why we are making the circuit very close. So the heat is generated at the active tip of the cannula, which is very, very concentrated heat, because we are going to keep the active tip at the target level where we are going to cause the lesion, either it is 80 degree or 60 degree or whatever. So after that, the heat dissipates. So the dissipated heat has to return back, and it has to exit somewhere. So it is like smooth landing. So in order to smooth land, we need a better runway. The runway is generally very big. So the passive electrode is like a runway where we create a bigger space, bigger surface area when we place it on your thigh or wherever. Thereby the returning heat gets dissipated, and the heat that reaches the skin will be very less, bare minimum, so that will not hurt the skin or burn the skin. So that is the concept of placing a passive electrode. So all these three will make one single circuit. So the voltage difference, how electrical energy becomes thermal. This is very, very important. This is the principle. This is the principle of the radio frequency. Many of the people think it is going to generate the active tip of the cannula is going to generate the heat like our cautery, what the surgeon use for cauterizing the tissues. No, it's a misnomer. Why I am using the term radio frequency term is a misnomer term. It is not that the radio frequency waves that is heating up, or it is not the current what you pass on to the radio frequency cannula, the active tip that is burning the tissues. No, you are only giving an electrical field, or you only giving a high frequency current to the active tip and then creating an electric field at the vicinity of the tissue where you are placing the active tip of the needle. You pass the electric current is going to create an electric field at that particular milieu, at the particular target or particular tissues. So there happens a movement of the ions because of the electrical field that is generated at the tip of the cannula. The movement of the ions is the one that is going to generate the heat. This is very, very important. Why this is very important? Because the tip of the cannula is whatever lesion you create, the tip is not going to be the part of the lesion. That is why if you see the lesioning happening, you keep the tip of the needle and then check it in the chicken breast. You see the needle tip will not produce. It's only the interface. It is the interface of the tissue and the needle where the heat develops, because the heat is not produced at the tip of the cannula. The current what you give is going to create an electric field there at the vicinity where you are making the ions move. The ions of the tissues, the anions and the cations of the particular tissues where you are placing the needle, it's going to oscillate. It is oscillating at a very high frequency or a very high speed. In that oscillation, due to friction, the heat generates. That is how the lesion is produced. That is how the thermal lesion or the heated lesions are produced at the vicinity of the radio frequency cannula. So the heat spreads the maximum heat is at the tip will not produce. The tip is not part of the lesion, but it is maximum at the tip and then it tapers. That is why it produces an inverted cone lesion. The conventional thermal RF produces an inverted cone lesion. That is because the temperature is maximum at the tip interface between the tip of the cannula and the tissues, which is maximum. And as it goes away from the tip, the interface temperature becomes less. So it becomes like a cone. So it is an inverted cone lesion where the heat is not going to be beyond the tip. At the same time, even the tip is also not part of the lesion. I want all of you to be very clear in this, because we need to know how the heat is generated there. As I said, it is an ionic movement. It is not the heat coming from the tip of the cannula. At the same time, how the shape, what is the shape of the lesion and why it is cone shaped? It is cone shaped because the heat generated between the needle tip and the interface is maximum. That is, you keep 65, it is 65, depending on the settings what you do. But the shape is inverted cone because it is maximum at the tip. As it comes towards the tail or towards the tail, body and the tail of the active tip, the temperature comes down gradually, and then it makes an inverted cone shape, where the tissues which is distal to the tip of the needle will not produce lesion. So this is a very important slide. I am summarizing once again. All of you have to keenly listen to this. So it is not the active tip that generates tip. The current what you give through the cannula, it produces an electric field at the vicinity. So the ions move, collide, and it produces the heat. The tip of the needle is not going to be the part of the lesion. It is the interface between the needle tip and the tissues, which is maximum at the tip, and it tapers down towards the body and the tail of the active tip, thereby producing an inverted cone lesion. There is no lesion which is going to happen distal to the tip. Very, very important. So that is the reason when your needle tip is little bit away from the target, you are not going to get the lesioning. At the same time, when you keep the needle perpendicular, active tip is perpendicular to the needle, it is not going to produce the lesion because there is no distal projection of the lesion. That is why in conventional radiofrequency ablation, the needle is placed parallel to the target, parallel to the nerve, thereby along the needle active tip where that inverted cone lesion produces, we can incorporate your target into the active, incorporate that nerve into the inverted cone lesioning of the tip. So in conventional radiofrequency ablation, the active tip should be placed parallel to the target. So that explains why. So this is the continuation of what I said. It is the generator, active electrode, patient grounding pad, the tissue heater, and the heat arises from the ionic motion, and the lesion size depends on various factors. It is about how long we are going to keep the temperature and what is the size and length of the active tip, and the tissue properties also. The tissue properties at that particular vicinity matters a lot. Like for example, if the tissue where you are heating has got more of a fluid, like if it is not dry, then the voltage which is going to take is more. So we have to be very careful because in this situation only sometimes that burns can happen because the voltage has the generator will have to increase the voltage by itself to create the lesion there by counteracting that fluid milieu in that particular site. But if the site is very dry, then it will not increase the voltage by itself to create the lesion. So depending on the tissue characteristics, it auto-adjusts itself by altering its velocity and thereby produces the heat accordingly and then do the lesion. So this is the slide I told why it is inverted cone. So the inverted cone, the radius is maximum at the proximal portion of the active tip. Again, the active tip is not going to be the part of the lesion. So, and I also told you why it has to be placed parallel to the needle. So these are all pertaining to the conventional radiofrequency ablation. So here the pain relief is mainly attributed to the coagulative necrosis of the nerve fibers and the Valerian degeneration. Because of the Valerian degeneration and the coagulation necrosis of the nerve fibers, the pain relief you are getting. So you're basically charring that nerve. You're doing complete coagulation of that nerve fibers, destroying the nerve fibers, and thereby interrupting the pain signals. That is how your conventional radiofrequency ablation works. So as I mentioned, these are all the characteristics that are very important. So the size of the electrode really matters a lot. So you use a 5 millimeter tip and you use the 10 millimeter tip, both has got a different characteristics of the lesion. The longer the active tip, the bigger is the lesion. And the temperature I mentioned, like if the internal milieu is more fluid, then obviously like the voltage has to be increased by itself to reach that particular temperature, or else the lesioning will be subtle. The lesion will not be good. So that is why we have to keep watching. Sometimes like the graph takes a longer time to reach the ablating zone. That there is a line called ablating line. You said 80 degree, there is an 80 degree line. So if the internal milieu is more liquid, it will take long time, and you can appreciate the increase in the voltage because it is more fluid. The internal milieu is more fluid, so the voltage has to get increased to get that particular temperature. So it will take time. So keep watching the thermal equilibrium, keep watching the temperature of the tissues, and monitor the voltage of the tissues, which are very, very important. So this is also a very important slide. As you see here, T1 and T2. T1 is a graph with a longer active tip. T2 is a graph where we are doing the lesion with a shorter active tip. So as I mentioned, the more the length of the tip, the bigger is the lesion. So T1 is obviously a bigger lesion. You see the x-axis, you see the y-axis. The x-axis is the distance from the electrode tip. As you see, as you move away from the beginning, as you move away in the x-axis, horizontal axis, you can see the temperature dropping down. It's a typical sigmoid shape where the x-axis is the distance from the tip. So the lesion is very maximum at the probe tip. And you see at the T2 is a smaller probe. Again, it covers that small dark dots. the bigger square dots are the lesion area for a small probe lesioning. So obviously that is actually smaller than the small black dots, which is lesion produced by the larger probe. So larger probe has got a larger lesioning when compared to the smaller probe lesion. So that is what this indicates. And in between, somewhere between 42 to 45, you got the zone of reversibility. Zone of reversibility is the place where like the tissue will not get denatured, the target will not get denatured. It can still, there is a high possibility that it will come to our body temperature. But anything goes above 44 will cause complete coagulative necrosis. That is why we are keeping it at 42. In pulse radio frequency, why we are keeping it at 42? Even we don't want to reach the zone of the reversibility because there is some percentage it can go into coagulative necrosis even though you are in the zone of reversibility, even though majority will return back to the body temperature. So that is why we keep 42 degree as our cutoff for pulse radio frequency so that we are not going to do a coagulative necrosis or the neurodestruction to the nerves. So how to interpret these lesions? If you see like which is very close to the electrode, the active tip is close, which is the core heating where it happens, which is close to the electrode tip, where the tissue is heated the most. This is where the permanent lesion happens. The border zone is what I said is the border zone 42, where the temperature falls and tissue enters into a band labeled as the zone of reversibility. It can go either way, but mostly it comes to your body temperature. At a greater distance, the tissue temperature comes back to your body temperature. So the probe size effect is very important. The larger probe extends farther in the figure, indicating a longer heated path and a wider effective lesion. That is more important than compared to the smaller probe. So the probe size has got its own significance in the lesion size. So the modern radio frequency generators have got multiple frequencies you can choose. Sometimes, you want to do a high frequency, you want to do a high voltage, you can actually choose your high voltage. So conventionally, the voltage is 45 volts we do for pulse radio frequency. But if you want to give the pulse radio frequency at the higher voltage, you can alter it by choosing the appropriate. You increase the frequency, automatically the voltage increases. So, but the temperature remains static. So there are various settings. You can choose your timing of the lesion. In conventional radio frequency, you can choose the temperature. And in pulse radio frequency, you can choose between either low voltage or high voltage. So we have the newer machines have come with a lot of ability to adjust the frequencies.
के लिए उसको बोलना है.
So this is one such procedure I want all of you to master because this has got a very good evidence. The cervical medial branch radio frequency, and of late we are exploring more of the thoracic acid where you can do thoracic facet denervation. And we all know about how we do a lumbar facet denervation by doing a lumbar branch radiation. And for sacroiliac joint pain, you can do an L4, L5, L5. We call it yes. Whereas in other lumbar levels, this particular place, that is the junction between your superior articular process and the transverse process is medial, right? Then L4 medial branch, and we have got S1, S2, S3 lateral branches, which is at 2 o'clock, 1 o'clock, 3 o'clock, and 5 o'clock position of your first, second, and third sacral neural foramen. So these are all the 5 targets where we do thermal radiofrequency ablation to denervate the sacroiliac joint for the sacroiliac joint inflammation. We can do a paddle lesioning also off late, like where make one small incision, stab incision, pass the pads, keep it along S1, S2, S3 lateral border, and then you can do a lesion at one go. So either you can do individually or you can do a paddle lesioning. So the second thing, traditionally for trigeminal ganglion, it is always thermal. This is the only indication where right now I am doing conventional radiofrequency ablation. I want all of you to look into this particular list of indications. Whatever list I have mentioned, now I am doing all pulse radio. Me, in sense, most of the people are now moving into a pulse radio frequency because of the complications, to alleviate the complications or to diminish the complications related to the thermal ablation. But thermal for trigeminal ganglion alone, like the pulse radio frequency doesn't really work. So we give thermal radio frequency ablation, but that is also only at 65 degrees centigrade, not above it. So then we can do it for glossopharyngeal, spinopalatine, then sympathetic ganglion, radiofrequency ablation, mainly the lumbar sympathetic chain, stellate ganglion. They are all having a very, very high, very good results post RFA. And of late, lot of spine intradiscal radiofrequency ablation techniques are gaining popularity. And this is really going to come up in a real big way. Especially the basivertebral now radiofrequency ablation and the bioculoplasties of intradiscal bioculoplasties. These are all coming up with a very good recommendations and very good evidences. And dorsal root ganglion also is one of the indication, but of late we stopped doing because it's now coming. The recommendation is strongly against because of the deficit. For dorsal root ganglion, now the pulse radiofrequency has become the gold standard. So this is because unless I tell you what is thermal, then you will not appreciate what is pulse. So that's why I spend so much time now in highlighting the physics in conventional radiofrequency before we move to a pulse radiofrequency ablation. So we know the physics of conventional, pretty much it is all same in pulse, but there is slight difference. So thanks to Sluger. Sluger is the one who made a lot of work in pulse radiofrequency. You believe he started doing pulse radiofrequency in 1998. You believe. Nobody can just believe. 1998. He belongs to Switzerland, and Switzerland started doing pulse radiofrequency ablation in 1998. Like, way ahead. We are giving a continuous lesioning. See, we are giving a pass. That pass is significant pass. You see the first top picture, that is your conventional continuous radiofrequency ablation. But if you see the waveform which is below, that is your pulse radiofrequency, where it is all the same. You are still giving the electric current to the electrode, but you are giving a pause. That pause is very important. That is 480 milliseconds between the electrical current what you deliver. So electrical burn and ionic friction happens and heat is formed. That is only 20 milliseconds. After you give that, stop it. When the machine stops it, and it gives 480 milliseconds. So 20 milliseconds of current and 400 milliseconds of positive. So in this 480 milliseconds, what happens? Whatever the heat that generated on the tip of the electrode, at the tip of the cannula, it has got the sufficient time for the temperature not to get propagated or not to get mounted. So that is the reason it stays at 42 degrees centigrade. It is not going to go up. Give the current, make the ion friction, create heat, then stop it. So the heat generates and make sure it won't cross 42 degrees. So that is mainly because of these two things. A short pulse width and a larger, the pulse gap is 480 milliseconds. The pulse width is 480. So it won't allow the temperature to mount more than 42 degrees centigrade. So this is the exact the mechanism why the 42 degrees centigrade is targeted and why it is not going up. In the previous curve, in the picture I told you, 40 to 44 is the zone of reversibility. So we are keeping it at 42. That is proven on your rat models and animal models. They have tested. In the lab models, in the animal models, they tested and they found 42 and above, there is a possibility of coagulation necrosis. So that is the reason we are setting it at 42. So if you have to stop it at 42 degrees centigrade, you have to allow only 20 milliseconds of electrical current given to the probe and give 480 milliseconds gap. That exactly takes the temperature at the target to only 42 degrees centigrade, not beyond it. So that is how the pulse radio frequency works. The rest everything is the same like your conventional. This also works by giving an alternative current to the probe and then make the ion, create an electrical field there, make the ion friction. But you give the positivity of 480 degree millisecond is what is the difference between your conventional and your pulse radio frequency. So thereby the tissue injury is very less. It is not a neurodestructive technique. It is only going to neuromodulate. We are going to come there. We are going to talk elaborately on how the pulse radio frequency really work. So as a whole, the clinical advantage of pulsed over conventional is it is only 42 degrees, so that the tissue injury is minimal. And thereby the complication rates. What I mean, the complication rate, the thermal injury, the neuritis, what you produce because of the thermal lesioning is less. And there is something called deaffrontation. At the thermal lesioning, what happened? That creates an aberrancy, that creates a neuroma. You char the nerve, and what happened? That charred nerve will sprout, and then it makes an arc, and then that leads to a deaffrontation. Like that aberrant arc of the pain arc that forms at the neuroma due to the thermal lesion is called a deaffrontation, which is one of the very, very painful conditions to treat. So we are not going to face any problem. See, this picture clearly tells it is a self-explanatory. The left side you see your continuous radio frequency ablation or your thermal ablation, where it is causing a coagulative necrosis of the nerve, and also the surrounding tissues where it is 80 degrees centigrade at the vicinity, and then the temperature, the heat comes down as it goes towards the periphery and it reaches 40 degrees towards the periphery. But you take the right side where it is pulsed, there is no coagulative necrosis. You are creating a electrical field, making the ion moves, but you are giving that short burst, the 480 seconds short gap, pulse gap, so that it is only taking the temperature to 42 degrees centigrade and which is even. That is the biggest difference. You see in left side, only at the structure which is close to that active tip gets ablated. What if the nerve is little bit away to the tip of the probe? It is not going to be a part of the lesion. And what if the structure is distal to the probe? It is not going to include in the lesion. So that is the biggest setback of continuous radio frequency ablation, where you have to place the active tip of the needle parallel to the target. Or else the lesion is or else you're not going to lesion the target. But radio frequency is not like that. Contrarily, pulsed radio frequency, you can reach the target perpendicular because it is working by different mechanisms. It is not causing a coagulative necrosis. It creates a electromagnetic field there, which is very equally spreading. So even you try to reach that now perpendicular, still you are bringing the, not the lesion, the neuromodulation, the target into the neuromodulation. So that is why, because this is very important when you are practicing, sometimes to get that least active tip of the needle parallel to the target is very difficult. For example, you do a lumbar medial branch block, you go easiest way to reach that gun barrel view, easiest way to reach that Scotty dog eye is your coaxial view or the gun barrel view. It's very easy. Even for the beginners, they will be very happy to see the eye of the Scotty dog where you place the needle in gun barrel. But you place the needle at the Scottish dog eye, not parallel, like gun barrel view, the conventional radio frequency fails. But you can still do a pulse radio frequency there, and then still it produces a good result, even though you reach it perpendicular to the targets. So that we call it as a neuromodulation. So I would like to talk about the mechanism of action of the pulse radio frequency. So what is the mechanism? This one particular slide will tell it works by three different mechanisms. One is at the molecular level, what are all the changes, and at the neuronal activity, what are all the changes, and exactly what happens to the structure of the pain fibers. In these three headings, we are going to see how it really reduces the pain. This is a very, very important next few slides, because like there is a big pulse radio frequency lobbies coming up, and they say the pulse radio frequency is better over conventional based on these particular pain reducing mechanism. So let us see one by one. So what are all the changes that acts at the molecular level? So this is the one such. We all know what is microglial cells. Microglial cells is a part of our neuronal system. It is there in all the nerves. So the dorsal horn, the dorsal horn is a structure which is in the dorsal horn neuron, or the dorsal horn structures is a very important structure in the spinal cord where your sensory nerve endings, your primary afferent nerves, the sensory nerves, it forms the dorsal root ganglion. After that, it goes and then relays at the dorsal horn nucleus of your spinal cord. There are the microglial cells at the dorsal horn nuclei are the key drivers of the neuroinflammation. So whatever that sensitivity we are talking, central sensitivity, like in one place, if there is a pathology happening, ongoing pathology is happening and you are not addressing, so the peripheral sensitization takes place. An injury is happening there, continuously happening. So the primary afferent nerves from the target goes and then continuously relays the pain signals into the dorsal horn nuclei. And in the dorsal horn nuclei, because of this microglial cells activation or the upregulation of the microglial cells, the neural inflammation is happening. This is called signaling. The signaling happens at the dorsal root ganglion, dorsal root horn or the dorsal root ganglion, both I can say. So the microglial cells at the dorsal horn, the DRG, dorsal root ganglion, and the dorsal horn of the spinal cord, the continuous inputs from the primary afferent will upregulate the microglial cells, and thereby it cascades the pain signals coming from the periphery and sends in a magnified way to the central nervous system, and thereby the sensitization happens. This is the main pathophysiology of your chronic pain. In chronic pain, this is the main physiology. The central sensitization is the main pathophysiology. So the continuous ongoing injury happens peripherally, leads to peripheral sensitization. The primary afferent takes the continuous pain signals to your dorsal horn nuclei of the spinal cord, where the microglial cells gets upregulated and neural inflammation happens, neural signaling happens, that cascades and sends to the central nervous system for central sensitization. So these microglial cells are present in the dorsal horn and also in the dorsal root ganglion, both. So obviously dorsal horn is a part of the spinal cord where we cannot reach, but dorsal root ganglion we can reach safely, fluoroscopically, and we can do a pulse radio frequency. So the pulse radio frequency down regulates the microglial activation. So when microglial upregulation is the cause for your central sensitization, your pulse radio frequency is down regulating the microglial upregulation. So it is reversing the upregulation of the microglial cells at the dorsal root ganglion, and thereby the neural signaling, the neural cascading is obliterated, is obtended. That amplification is stopped. That nociceptive signaling is stopped. That nociceptive amplification is stopped. So that is how we are targeting the dorsal root ganglion to downregulate the microglial cells. So that is the main pathophysiology of how the pulse radio frequency really works in diminishing the pain, especially the neuropathic pain. So the Shaw et al. Has done a lot of research. You see, he has published one in 2013 and one in 2016. So he has done the pulse radio frequency of the dorsal root ganglion, and at 40th day, they have found out the microglial deactivation has happened. Similarly, one more published in 2016 where they have done caudal pulse radio. Even there are many centers, they do a pulse radio frequency in the caudal epidural space. But what is the difference? In caudal epidural space, we will do it at a very smaller time and a higher frequency. In caudal epidural space, in the dorsal root ganglion, we do it for 120 seconds and you will do it at 45 volts. But here, contrarily, in caudal, we will do it a longer duration and lesser voltage. The voltage what we choose for caudal PRF is only 5 to 10 volts. But the time what you give in 8 to 10 minutes you can give. So that is the difference. There are many centers where they do the low voltage caudal pulse radio frequency ablation. And imagine, this is not a very old paper. This is published in 2016, just 10 years back, where they have done the caudal pulse radio frequency and they proved the microglial microbial deactivation happened at the 14th day. So that is how this is called actually the neuromodulation. What I have described so far is the neuromodulation. What happens at the molecular level in the microglial cells of the dorsal root ganglion, and how this pulse radiofrequency ablation is downregulating it is what we call it as neuromodulation. We keep hearing neuromodulation, but this is what is neuromodulation. So if you can read this particular, you can note it down. This is a very good paper published in 2022. It's a South Korean paper by Yugnam, where it is the pathophysiology and the mechanism of action of how this pulse radiofrequency works is beautifully mentioned. So coming to the next mechanism, the next mechanism is like it is got role in anti-inflammatory also. First, I was talking about microglia. It down regulates the microglial cells. Secondly, it actually reduces the pro-inflammatory cytokines. How? Because the cytokines are also observed in DRG and in dorsal root ganglion in nerve injury models. Like if the injury happens peripherally, they see like there is elevated cytokines level in DRG and the spinal dorsal root ganglion. So what happens basically, there happens a gene expression here. There are a lot of genes expression happen. One such gene here is your CFOS gene. So once the CFOS gene expression happens, what happens? It actually modulates that dorsal root ganglion by reducing the release of the pro-inflammatory cytokines, especially interleukin 6, interleukin 1 beta, and TNF alpha. These three are the main cytokines that are released from the dorsal root ganglion due to an inflammatory pathology or an ongoing inflammatory injury which is happening. So these are all the three pro-inflammatory mediators or the inflammatory mediators released at the DRG. And Vallejo has done a wonderful work on this. It is also published in 2013 and Jiang et al. In 2019. And they found the pulse radiofrequency you delivered. One has done in dorsal root ganglion, that Vallejo has done the pulse radiofrequency of the alpha dorsal root ganglia, and then he documented. He has done the assay, ELISA assay. He has done the ELISA and then found the interleukin 6 and tumor necrosis alpha return to normal, and thereby it diminishes the allodanium. And similarly, Jiang et al. Has done in sciatic nerve. So that is what is, even you can do a PRF in a peripheral nerve, but still the inflammatory mediators is coming down. So he proved the interleukin 1 beta tumor necrosing factor alpha is diminished. It returned to baseline, and then it is diminishing the hyperalgesia symptom. So this is mainly because of the modulation of the inflammatory gene expression. There are many gene expression. There are many genes that expresses the inflammation. One is the CFOS gene. So CFOS gene expressions is modulated by the PRF, and thereby the inflammatory mediators are returned to the baseline by doing the pulse radiofrequency ablation. So then what happens to another mechanism? Another mechanism is like it stimulates your endogenous opioids. We give opioids by external means, but we know we have got an endogenous opioid secreted in the body, both from the central nervous system and peripheral nervous system. So Moffat et al. Has found beautifully that the pulse radiofrequency has got a capacity to stimulate the precursors of the endogenous opioids. See, all the endogenous opioids, what we say, the endorphins, enkephalins, dynorphins, they are all like endogenous opioids we have seen. See, the endogenous opioids, we know you do good physical exercise, you do yoga, you do running, you do swimming, you play cricket, you do some sporting activity, you feel good because the endogenous opioids are secreted in the body. So that is giving an analgesic effect. So what this pulse radiofrequency is doing, you do a pulse radiofrequency of your peripheral nerve or the DRG, it is releasing the precursors for the endogenous opioids. These are all the precursors. They are like proenkephalin, promelanocortin, and prodynorphin. So these are all the precursors of your endogenous opioids, which are stimulated by your pulse radiofrequency of your DRG or the peripheral nerve, and thereby it is producing the analgesic effect. So it is like giving fentanyl or morphine from external means. The PRF is inducing our body innate ability to produce its own opioids and then producing the analgesic effect secondary to that. So the next proposed path, the reason why mechanism by which the pulse radiofrequency works is like it is acting on the inhibiting pathway as well. So we have got an ascending pathway and descending pathway. You feel the pain because of the activated ascending pathway, and then the ascending pathway gets activated or the descending pathway gets inhibited. So if the descending pathway gets inhibited, you get pain. So one of the treatment for pain management is activating the descending inhibitory pathway. The descending pathway has to be stimulated or has to be activated. So what are all the neuronal systems in the inhibitory pain pathway? One is noradrenergic, another one is serotonergic. They are mainly in the hippocampus. They are mainly in the hippocampal area and thalamic and subthalamic area where these inhibitory pathways will be there. So what happens? You have to accentuate, you have to augment, or you have to activate the descending inhibitory pathway to have a very good analgesic effect. So similarly, the PRF has got the capacity to stimulate the descending inhibitory pathway, thereby it gives an analgesic role. You see this particular slide, I want to highlight here. See, Agiwara has done a wonderful in 2009, he has done this particular study. What he has done, he has stimulated the pain. He has strangulated, he has ligated one sciatic nerve and produced an inflammation, and then he created the pain. And then he gave a pulse radio frequency. Once the pulse radio frequency is given to the sciatic nerve, for whatever mechanism we saw before, we discussed before, the pain has come down. What they has done, after the pain comes down, he has given intelligently one alpha-2 blocker and one serotonergic antagonist, because both are the noradrenergic and serotonergic blockers. So once the serotonergic and noradrenergic receptors goes and blocked by this methysergide and yohibine, so you are blocking it. It is like blocking the inhibitory pathway. So once this inhibitory pathway is blocked, the pain has resurfaced. So thereby they have proved the PRF has reduced the pain because of activating the inhibitory pain pathway, but it can be reversed by giving a alpha-2 adrenergic antagonist and your serotonergic antagonist. So he has proven that the PRF has got a definitive role in augmenting or in activating the descending inhibitory pathway, which plays a key role in analgesia. So this is one of the proposed mechanism for pain relieving due to your pulse radio frequency. This is the last one. This is actually our Sardar Reddy, who is the founding father of World Institute of Pain. He has published in 2009. He is totally differed from rest of the mechanism. He is telling the pulse radio frequency is neurodestructive. I have to complete this talk. So I have to tell you, there are papers which are saying pulse radio frequency is also a neurodestructive procedure like your conventional radio frequency, but it has got a subtle ultrastructural effects unlike your conventional radio frequency ablation. So according to Sardar Reddy, he published in 2009, the PRF is going to work like your conventional radio frequency ablation because it also can cause damage to the nerve membranes, mitochondria and microtubules. So he is the one who is deviating from the non-neurodestructive mechanism of your pulse radio frequency ablation. He believes the PRF is also producing pain relief like your conventional radio frequency ablation due to the damage it causes to the nerve fibers. So the indications is more or less the same what we see for the conventional. You see here the dorsal root ganglion radio frequency ablation. This is one particular procedure I almost do every day. Dorsal root ganglion pulse radio frequency has got a very good evidences. The indications are many. The indications for any radicular pain of any etiology, it may be a disc bulge causing your nerve root pain, we can do it. Or post-herpetic neuralgia causing dermatal pain, you can do. Or a cervical radicular pain causing due to a cervical disc osteophyte complex, you can do. Any pain which is having a radicular pattern, you can still do a dorsal root ganglion radiofrequency ablation. This has got a role to play even in cancer, where your sarcomas pressing on the nerve roots causing your pain, still you can do, even though it is a peripheral nerve. We have discussed in our previous slides, even the peripheral nerve pulse radio frequency RFA has got the better analgesic effect, but we can always go above and then we can do a PRF at the dorsal root ganglion even in peripheral nerve pathologies. And if you see the next indication, I had done almost all this nerve pulsed RFA, the occipital nerve pulsed RFA. Don't do a conventional RFA, let me tell you, because it can cause deafferentation, it can cause neuritis pain. Patient comes with an occipital headache due to a nerve entrapment of your greater occipital neuralgia. It is very classical. They will have pain on the nape of the neck that goes to the vertex. So people are very easy to find out that we can do a lesioning at the greater occipital protuberance ultrasound guided, you can see the occipital artery, go lateral to it, see the nerve and then ablate it. Or you can go proximally at the C2, C1 junction between your supraspinatus, semispinalis capitis muscle and inferior oblique rhomboides muscle. You can see that plane, nice, greater occipital. Now we can go and then do the ablation. But what if you do a conventional RFA? You do a conventional RFA, you are lesioning it. So two problems we can face here. One is because it's a peripheral now, you do a thermal RFA, there is a high chance it can go into deafferentation or the neuritis. That pain can worsen sometimes. I have seen patient after thermal RFA of the occipital now comes back with a very severe occipital neuralgia. That is because you are causing neuritis by doing a thermal lesion. Rather, you do a pulse radio frequency, you are neuromodulating it. And how much to give, how to give, we are all going to discuss now. But do a pulse radio frequency, you get very good relief, long-lasting relief without having a neuritic pain. So I stopped doing thermal RFA for occipital now, suprascapular now, ilioinguinal now, iliohypogastric now. And I mentioned before the start of the talk, I did one intercostal now pulsed RFA for a post-thoracotomy pain 2 days back. I stopped doing thermal RFA because the pulsed RFA is giving a very good result, but you should know how to choose your settings, which we are going to discuss in the next part of the talk in another few minutes time. So the indications for your intradiscal PRF is increasing. We're all going to do that very soon because of the neuromodulation technique. And caudal epidural, people are doing PRF at little longer duration but lesser voltage because they are all mixed nerves. So at the higher voltage, there is a possibility you get numbness. So keep the voltage less than 10. Usually 45 voltage is what we give for pulsed RFA conventional, but you can increase the voltage up to 90 and you can bring the voltage less than 10. So for the caudal epidural PRF, you can keep the voltage less than 10, which is highly very effective, especially in failed back spine. In failed back spine cases, pulsed RFA of caudal epidural is equally effective like your caudal neuroplasty. And whatever conventional indications we see for the conventional RFA like medial branch RFA, we can do pulsed. Trigeminal is one area, except for the ophthalmic neuralgia, I use only trigeminal neuralgia is the only condition, or trigeminal ganglion is the only structure where I do thermal, where the pulse has got no role, except the ophthalmic neuralgia. Obviously, we cannot do a thermal lesioning because it can cause corneal anesthesia because ophthalmic nerve supplies the cornea. So where over the pulse radio frequency, you have got an ultra extended euthermic pulse RF. But the only very few RFA machine has got this particular. In fact, in India, no vendors are giving this particular options to us because this is basically a room temperature. It is only 37 degrees. It is not even 42 degrees. At 37 degree, at an extended duration, you do pulsed RFA. You are not causing corneal anesthesia for ophthalmic neuralgia. So that is one thing we need to remember. For ophthalmic neuralgia, even pulse radio frequency can cause corneal anesthesia. That then Sardar Reddy told is correct. So which means there is a possibility even pulse radio frequency can cause structural damage. That is why for ophthalmic neuralgia, we are not doing pulsed, we are doing ultra extended euthermic, where the temperature is only 37, not 42. It is pulsed, but at our body temperature, not at 42. So then we can do a pulse radio frequency for spinopelvic, again spinopalatal ganglion, very sensitive. For cluster headache, you do. We have been doing thermal, but the problem with the thermal again is headache. I have done thermal RFA for one spinopalatal patient. Patient was having a severe supraorbital pain. So now all these things you can avoid by doing a high voltage pulse radio frequency ablation. Thereby, there is no problem of deafferentation or the neuritic pain. Similarly, the sympathetic ganglia and the visceral sympathetic, all traditionally conventional has been done. We can do a pulse radio frequency ablation with the same result and the same longevity. This is my own paper I published in 2021. This is about your liposarcoma of the pelvis. Patient was having a liposarcomatous lesion at the before the S1 sacral promontory, and the lesion was extending to the left side of the S1, S2 neural foramina, and it extended to the piriformis muscle, and also it extended to the greater sciatic foramen, and it was encasing the lumbosacral plexus. So your patient was having CRPS type 2 of the left lower limb. He was having a swollen limb, shiny limb, severe pain, very disproportionately high pain. So we did, I did L3 to S1, L3, L4, L5, S1. dorsal root ganglion of the pulse radio frequency of the dorsal root ganglion of the L3 to S1, which very, very promising result. It's been almost 4 years. Patient is still having pain. You see, it is published in 2021. It's been 5 years. If we have a good 5 years follow-up, patient is having good pain relief till now. So this is how I did this one, L4, L5, S1. So the needle tip has to be at the 6 o'clock position at the corresponding pedicle where the dorsal root ganglion is placed, and then you have to stimulate it, and then you have to do the RFA. So this is one of my, this is again my publication. This is, I published little before. I think this I have published in 2000, maybe 18 or 19. I mean, before, 2018. This is for one neurofibromatosis type 1 involving the brachial plexus. So patient, the stellate ganglion, the cervical sympathetic ganglion or the stellate ganglion RFA has been done. And the patient's pain was predominantly your upper radicular pain, mainly on the thumb and the index finger, because of the neurofibromatosis lesion at the C5 and C6 nerve roots at the axilla. So the RFA was done in the cervical sympathetic chain at C6 level, which was, and it is a pulse radio frequency ablation where the patient had got a very good lasting relief. Again, you do a conventional radio frequency ablation. There is a possibility of the neuritic pain being increased, and there is a possibility of the Horner syndrome, which is actually aesthetically not acceptable. One of the biggest problem with this stellate ganglion or the cervical sympathetic chain RFA is the meiosis. It's one of the component of Horner's, which is aesthetically not acceptable. One eye is drooped, and you do a conventional RFA, we never know when it is going to get back. One of the patient, I did a conventional RFA, patient took 6 months for the meiosis to get back to normal. So till that 6 months time, patient was aesthetically bad. Some patients may sue you if you actually don't explain the effects of your conventional RFA of cervical sympathetic chain. But we can avoid all these things in the pulse radio frequency ablation. So these are all one of the paper on pudendal nerve RFA published in the Pain Physician, where the pudendal nerve is entrapped at the tunnel between the sacrospinous and sacrotuberous ligament. So the patient, the diagnostic block of the piriform is the sacra, the caudal epidural, everything has been done, but the patient didn't get the relief. But the moment the pudendal nerve diagnostic block is given, the patient got a very good relief. And post-diagnostic block, more than 50% pain relief achieved. The pulse radio frequency ablation was performed. It was done. It was not done by me. It's a paper published in New York by Ellen. And then he found the pulse radio frequency of the pudendal nerve is one of the very good technique with a promising result, with the good evidence for nerve entrapment, pudendal neuralgia. Similarly, on the right side, there is one paper. It's actually a double-blinded sham control study on the radio frequency on the post-surgical. This is again a pulse radio frequency. This is a post-inguinal pain. It is 25 to 30% incident. The post-inguinal nerve entrapment in inguinodynia is 25 to 30%. I treat a lot of inguinodynias post-inguinal where I do only pulsed, because ilioinguinal, iliohypogastric nerves are mixed nerves. It is supplying motor to your intercostal abdominal muscles. So you ablate those nerves, what happened? The lower abdominal muscles become weak. And once I have done the conventional RFA, I had seen patient coming and telling me they have got some lump in the lower abdomen. You will not believe, because of this abdominal muscles weak, their abdominal contents got really bulged out. As they rightly said, the right side, because there is of your abdominal muscles, and thereby all the bowel loops come out. So I stopped doing conventional RFA of your ilioinguinal, iliohypogastric. Now I completely moved into pulse radio frequency. And this is one paper that is clearly stating very good promising result of the inguinodynia post inguinorrhaphy surgery. So this is another area where I see the pulse radio frequency infrapatellar branch of the saphenous nerve. This is how you have to do. Draw one. I have some time. Do I have some time?
Sir, please,
Yes,
please.
sir. Please carry on, sir.
Okay. Anyway, I will finish it in another 5 minutes. I'm sorry. I have a few more slides to go. So this infrapatellar branch of your saphenous nerve is done like this. You see, like draw one line, choose the inferior, mark the inferior border of the patella and mark the tibialis, that tibial plateau. Draw a horizontal line, 4 finger breadths away from the midline, make one a line parallel, and then you place your probe there. And that is the place where you see the medial collateral ligament. That's a medial joint line. In that medial collateral ligament, where it attaches at the tibial bone, above the medial collateral ligament, you can see a nice dot-like structure just above the MCL. Branch of saphenous. Sometimes you put the ultrasound probe and do a local anesthetic and steroid. The post-knee arthroplastic neuropathic pain will get subsided very much. But you do a pulse RFA, it really helps. Nowadays, what I'm doing, even osteoarthritic patient, not an operated ones, I'm actually doing 7 lesions for my knee denervation. I'm including this infrapatellar branch pulsed RFA as the 7th lesion. But I'm not doing a thermal RFA or cooled RFA because this is one structure which is very, very superficial. The infrapatellar branch of saphenous nerve is just underneath the skin and subcutaneous tissue. I would say it is just about half centimeter from the skin. And where you do a thermal lesion, you are causing skin necrosis. So this is the only nerve of the 7. See, the type of needle, what you choose matters a lot. As I mentioned, the active tip is longer, the lesion produces is bigger. The curved tip produces a bigger tip, and the protruding electrodes, like sometimes like a cobra tongue, it is now split as that electrode that comes out will be split. So once it is split and protruding, it produces much bigger lesion. So nowadays, with the needle, lot of changes and advancements are happening. Thereby, you can create more effective lesioning. And of course, the second part, needling techniques matters a lot. That is the key thing. That's the core thing. That's the crux of the procedure. Like you are not in the right target, obviously, like whatever modality you choose, it's not going to help. So know your anatomy very well. And that is going to, you place the ideal target, then obviously the results are going to be. Then comes the important thing, RF setting. We are going to talk about that. What is the RF setting we have to choose when you are doing a pulse radiofrequency ablation and how it is going to influence? See, I told you about the mechanisms and the principles in RFA that it is only causing 42 degrees centigrade. I agree. That 42-degree temperature is fixed, but voltage you can choose. It is your choice. You increase the frequency, the voltage increases. You decrease the frequency. Normally it is 2 hertz. By default settings, you choose pulse radiofrequency mode in your RF ablator. It selects only 2 hertz. You want to give more voltage, increase it to 5. You want to give less voltage, decrease it to 1 or 0.5. It is very simple. You decrease the frequency, the voltage decreases. You increase the frequency, voltage increases. So what is the difference between your low voltage and the high voltage? Why you want to give high voltage? This is simple. See, low voltage is between 30 to 45, it selects by default, but you want to give it the higher voltage, adjust the setting, increase the frequency, the voltage increases. You want 4, you make it 4 hertz, it will become somewhere between 70 to 80. Make it 5, it becomes 90. The advantage is you increase the voltage, the electric field what you create at the vicinity is more. More ionic friction happens. So what happens? The field is strong. So the lesioning is very effective and the lesion size is bigger, widespread. Thereby the nerves get captured. You see this slide. This shows very clearly. The higher voltage group produces an enhanced neuromodulation and it will cause some surgical structural changes like Sardar Erdin told. Some mitochondrial cell membrane disruption takes place. Along with neuromodulation, but ultimately the pain relief is more effective and long lasting. That is what is very important. See, you are doing this particular procedure for pain relief. What's the point? You're not giving the desired pain relief. What's the point? You're not giving a long lasting relief. By adapting to this higher voltage, pulse radiofrequency, you are achieving the longer lasting and also an effective pain relief. That is what I see. Nowadays, I completely moved into high voltage pulse radio frequency and compared to the low voltage pulse, except in trigeminal neuralgias and dorsal root ganglion. I have moved completely into a high. Of late, I have done one patient with high voltage pulse RFA, even on lumbar DRGs, and I have not found any deficit or any numbness of the limb. And all the thoracic dermatomes, I am doing only high frequency. With the lower dermatomes, with the lumbar dermatomes, we need to be careful with higher voltage because sometimes they say numbness of the leg. But thoracic dermatomes, close your eyes and you do a high voltage PRF, the results are very, very promising and long lasting. So the mechanism of the high voltage is same, neuromodulation, strong electric field, and more effective. Same, whatever mechanism we saw in pulse radio frequency, mechanism of action, pain relieving mechanism, they're all augmented with higher voltage. So these are all the papers. See, this is something, a paper published in Shenging Hospital in China. It's a very recent one in 2020, where they have done a pulse radio frequency of the different voltages for a patient with the post-herpetic neuralgia. They have included 109 patients. Okay. They divided into three parts, 30, 30, 30. I mean, 35, 35, 35. The first 35 group is group A. They had given 45 volt. Second group, 55 volt. Third group, 65 volt. You see the result. Patient in group C, that is the patient who received 65 volt pulse radio frequency, has got some slight numbness, but their pain relief is their pain relief is excellent and significant. See, the p-value is less than 0.05. Which is significant. It's statistically significant. Between 65 volt and 45 volt for a post-herpetic neuralgia of 109% steady, the higher voltage PRF has got statistically significant analgesia. The p-value is less than 0.05. That is why I put this. So they proved the higher voltage has got a superior efficacy when compared to the lower voltage. This is published in 2020 in Xiangjing Hospital of China Medical University, China. The next paper I want to see is a high voltage long duration. The previous paper is compared between the voltage. This particular paper is published again in Beijing in China in Capital Medical University. The Chen Li Sun and et al. Has conducted this. They have studied 64 patients, which is not less. 64 patients they studied. And then they have done a high voltage and long duration. How long? One group, they had given 120 seconds. That is only 2 minutes. And second group, they had studied with duration of 6 minutes. And third, they had studied with the duration of 12 minutes. So they found patient having a long duration PRF has got an improved pain relief when compared to short duration. So first we saw the higher voltage has got the better analgesic effect and longevity. And now we are seeing long duration. So we were all taught before the pulse radio frequency is 120 seconds. Can you imagine? I'm giving these days minimum 12 minutes. One patient I had done PRF for 20 minutes. 20 minutes I have done the pulse radio frequency ablation where I am seeing a promising result. So now another factor that is influencing the success of your PRF is the duration of the lesioning apart from your voltage. So high voltage clubbed with the long duration is having a very good success rate. And you see this is another paper adding to the high voltage and long duration repeated. You may come across a situation where patient will be having CRPS, very challenging, treated by many doctors, many pain specialists, still they will having chronicity and they're having a central sensitization, very difficult. So you give high voltage, you give long duration, and you repeat every 2 weeks. Repeated every 2 weeks, give 3 sessions or 4 sessions. The results are better. This is again published in Jiaqing in China by Enming et al. So they have done this 3 to 4 times within a span of 2 weeks. Within the span of 2 weeks, they repeated this high voltage long duration and they found repeated high voltage long duration is more effective than just a high voltage and long duration. So first we saw long duration, when high voltage, then long duration, now repeated high voltage long duration. This is how the pulse radio frequency is now evolving. So now, what are all the other things along with that it can help? So this is an effective treatment of this is about the first branch. This we already discussed. This is definitely having a very, I was talking about ultra extended euthermic one. So obviously for an ophthalmic nerve, we cannot be doing a conventional RFA. That is what this particular study published in 2021 in Shenging Hospital in China, where they have proven the success rate of the supraorbital nerve pulsed RFA. Just imagine, this is not ophthalmic now. You see, this is a peripheral now. You see the conclusion, the efficacy of the high voltage PRF of supraorbital now. So you don't need to go into the foramen ovale. The supraorbital now you can capture supraorbitally just above the supraorbital foramen and do a PRF. Never attempt a conventional RFA of supraorbital now, because again it's a superficial now. You can cause skin damage, skin necrosis, and the incident of deafferentation pain is very high if you do a thermal ablation of the supraorbital nerve. I have done many PRF of supraorbital nerve for ophthalmic neuralgia, secondary to trigeminal neuralgia, having a very good promising result. So this is one study published again in China, in Jiacheng, where along with pulse radiofrequency ablation, the triamcinolone steroid and also the ozone has been injected. So there are some adjuvants. This is basically adjuvant. But in my practice, in pulse radiofrequency ablation, I never give anything. Imagine I won't even give local. No local anesthetic, no steroid. Just to go do a skin local infiltration, that's all. Go give 12 minutes to 15 minutes of pulsed RFA, that's enough. Giving the local anesthetic after the pulsed RFA, giving a triamcinolone, they are all not adding any benefits. If you compare these two, you do one group of patients with only PRF without steroid, you do another set PRF with steroid, there is no difference. So why unnecessarily to give steroid? So I don't really believe on this paper, like people can combine with steroid or ozone, but just mere PRFA alone, if you are doing it properly, it gives a very long lasting and durable relief and an effective pain relief, as we discussed before. So to summarize, last 1 hour, what we have discussed, knowing the anatomy is very important. Whatever, whether it is a pulsed or a conventional or your cooled RFA, doesn't matter. Know the anatomy, and then you are mastering the needling technique is very important. If you lose the anatomy, if you miss the anatomy, if your target is missed, whatever technique, whether pulsed or whatever modality used, it's of no use. Know the device. I am telling you, see, I spoke so much about how to choose the frequency, how to choose the voltage. So knowing the device is very important. The machine is not the master. You are the master. You are mastering the machine. You are telling the machine. We are in the AI world where everything we can say AI to do, and robotic. We are in the robotic age where robo is doing. But whatever certain time, the one who masters the robo, the one who masters the AI is you. So we have to know the device, how to use the device, how to choose the parameters for the effective listening is very important. And between the fluoroscopy and ultrasound, it is your expertise. For some structures, of course, I use ultrasound alone. For prudental, cervical sympathetic chain, they are all like facial structures where I don't go with the bony landmark, I use ultrasound. For few structures like dorsal root ganglion, they are little deeper structures, I use fluoroscopy. So try to master both. Sometimes I follow hybrid, sometimes I follow one. Depending on my experience and my confidence, I use the modality. I use the imaging modality, what I mean. So, and pulse produces a very, very effective pain relief through neuromodulation with very, very minimal thermal damage. It's a very safer alternative to CRF, and whatever indications are there for CRF, we can use the pulse radio frequency for the same indications. Thank you so much.
Sir,
Thank you,
what-
sir. Thank you, sir, for the excellent presentation. So,
Thank you.
So pulsed RF is having its own advantage of nerve preservation, tissue damage, tissue sparing effect,
Yeah.
and is a safer. Any disadvantage over conventional radio frequency?
The disadvantage of pulse radio frequency, as such, I don't see any disadvantage. A lot of noise I keep hearing, it is only placebo, it won't work like that. But in my experience, I see a very promising result with pulse radio frequency ablation. And as I said, it is a very safe alternative to conventional RFA. between conventional RFA and pulsed RFA, the disadvantage of pulsed RFA over conventional RFA, I really don't see. For whatever conventional RFA indications are there, you can do a pulsed RFA. But other way around is not true. Obviously, like if there is for all pulsed RFA cases, you cannot do a conventional RFA. Like ophthalmic neuralgia, you can't do a thermal RFA because it can cause numbness. So I think that I don't see any downside or any disadvantages of pulse radio frequency over. In fact, there are only advantages. One more advantage I told is you can reach the target perpendicular to each other. But unlike conventional RFA, where you have to place the active tip parallel to the target. So these are all the advantages. I actually speak, I don't see any disadvantage of pulse radio frequency over conventional RFA.
Any duration of effect?
The duration of the effect, like I mentioned, if it is a high voltage, say, I told you, no, the papers are telling the durability between the conventional RFA and the pulsed RFA is very simple. The conventional RFA is at second year or at the 18th month. If you see the post-procedure 18th month, the conventional RFA has got the better relief because traditionally it was told it is being published, the pulsed RFA will work only for 9 months to 12 months. But if you adopt this particular technique of high voltage, long duration, repeated technique, you are getting the more longevity, almost on par with conventional RFA and sometimes even more.
Thank you. We'll just quickly move
Anand sir,
to the
Anand,
chat box. Sir, Praveen sir will just first answer the queries mentioned in the
Yeah, in the chat box. Yeah.
Dr. Kyati Patel has asked, is caudal epidural pulse radio frequency for failback surgery syndrome or coxicodynia? Which nerves do you target and needle tip position on fluoro?
Wait, I'm just
you're able
trying to
see
see
the
that
chat
one.
box.
Now, can you repeat again? What is that? Where it is
In
written? Who
caudal
has asked?
epidural, in chat box, Dr. Kyati Patel.
Chat box I'm seeing in caudal epidural.
PRF for FBSS or coxicodynia, which nerves do you target? And needle tip position on fluoro.
See, for coccydynia, you can directly target sacrococcygeal nerves at the sacrococcygeal junction. Okay, you can go and then do a pulsed RFA there. You don't need to go and then do it at the caudal epidural space. Caudal epidural pulsed RFA is mainly for FBSS, the failed back spine surgery only, where you do a caudal neuroplasty. Instead of caudal neuroplasty, place this needle and then do an RFA. That's all.
The next question is by Dr. SL. Thank you very much for the wonderful talk, sir. What's the rationale for giving local anesthetic plus dextrose hydrodilatation after pulse radio frequency? Dr. Santosh.
As I mentioned, you can give dextrose, you can give Botox, you can give ozone, you can give local anesthetic, anything you can give because but in pulse radio frequency, if you ask me that the mechanism I explained to you so much, correct? In fact, like more than half an hour, I was talking about the various pain relieving mechanism in pulse radio frequency. Now you tell me, do you really need any of those adjuvant after PRF? Because the mechanism is totally different. It's not neurodestructive. It works by augmenting your descending pain pathway. It works by diminishing the release of your excitatory pain neurotransmitters like it is diminishing the neuroinflammatory mediators like cytokine, tumor necrosing factor, and then it is down regulating the microglia. It is working at the molecular level, and then it is decreasing the pain. How your local and how your other adjuvant, what you add after your PRFA is going to make a difference. I am not giving any adjuvant. But there are papers, I showed one, people are using ozone, people are using steroid after the pulsed RFA, but there is no need.
Okay, sir.
Anand sir.
5% dextrose is mainly for prolo. So in DRG settings, we won't use. Of course, for the peripheral nerve setting, you can do 5D. I have done 5D. That question may be relevant in one situation, like where if there is the pain is because of entrapment. Like for example, in pudendal nerve entrapment syndrome, where you see the nerve is entrapped, you do an ultrasound at the ischial spine level where you see the nerve is edematous, or you do a dorsoscapular nerve entrapment and you get the interscapular pain. You first do a hydrodissection with 5% dextrose, then you can do a PRF, or do a PRF first and then you can do a hydrodissection. So where you are taking care of the pain at the same time you are hydrodissecting the nerve from the entrapment and you are releasing the fibrosis. Any other question?
Anand sir,
Yeah.
after long discussion with you in the long drive, we had done 3 cases of high voltage long duration PRF.
Oh.
Two suprascapular, one supraorbital and GON.
Oh.
That supraorbital and GON patient is absolutely fine, migraine patient.
Oh.
The
Very nice.
suprascapular nerve patient, actually, still I need to follow up the patient.
Suprascapular, it's brilliant because suprascapular nerve is a mixed nerve.
Yes, sir.
It's a mixed nerve where ideally speaking, you should not even attempt thermal. It is actually contraindicated.
Yeah.
The thermal RF is contraindicated. And that is why for shoulder denervation, we are moving into articular branches. But if you want to really do a suprascapular RFA at the suprascapular notch, best is to do a pulsed RFA at high voltage.
Last case, Dr. Srikanth was also with me, sir, when I was doing high voltage PRF of suprascapular.
Okay. I want all of you to practice high voltage PRF, very safe.
Yes,
I started doing even lumbar DRG high voltage.
Sir, I have another question for you. My glabropharyngeal nerve PRF results are not great, sir. Glabropharyngeal neuralgia.
Which now?
Glabropharyngeal results are not great.
Glabropharyngeal now, I'll tell you, which pathology you did?
There are only 2 pathologies. One is stylalgia and the other is REZ vascular loop. For REZ vascular loops, always surgery is better than this glabropharyngeal nerve PRF, sir.
Yeah, vascular loop, you are doing a peripheral nerve will not work. Even you take trigeminal neuralgia due to a vascular loop, we are doing RFA at the root level only, at the ganglion level. Only then it helps. But glabropharyngeal now, what you are doing pulsed RFA is that at the stylomastoid foramen, am I right?
Yeah, sir.
At the exit of the stylomastoid foramen only, that is close to that styloid process approach, correct? Extraoral approach.
Yes, exactly.
Yeah, see, the pathology is proximal and you do RFA, distal will not work.
And even for stylalgias, it is not working that great, not doing that good results.
Yeah, even it is mixed. You mean to say that Eagle syndrome?
Yes, sir.
Yeah, Eagle syndrome, it is failing. That is because it's more mechanical. Because
so
it's an elongated styloid process and it is more mechanical. So that is why even I have a very... I know for glabropharyngeal neuralgia due to Eagle syndrome, the results are bad. Even I have done many, it all failed.
The only cases where glabropharyngeal neuralgia PRF working is this cancer patients with tonsillar malignancies.
Yeah. Tonsillar malignancies, it works. Yeah. Correct. You are right. Tonsillar malignancy, it has got a good relief. Correct.
Sir.
For maxillary, mandibular, all the buccal mucosa and all posterior pharyngeal, posterior tongue and all those things, piriformis post and all, you try sphenopalatine. It's very helpful.
Sir. Yeah. Sir, I have another question for you, sir. For pelvic visceral pain. Hello, sir.
Yeah, I'm hearing.
Pelvic visceral pain, the fine after sympathetic pathway, anyway, the nerves merge onto the dorsal root ganglion, sir.
Yeah.
Either sacral DRG or thoracolumbar DRG. Do you have any experience of doing DRG PRS for pelvic visceral pain, sir?
Yeah. One paper I produced, no. Oh, yeah, of course, that's a somatic pain, that pelvic liposarcoma I showed, in one of my slide. That's my own publication. That's my own paper published in Indian Journal of Pain, but that is not a visceral pain. That's a somatic pain. What happens that liposarcoma, you want the visceral pain you're asking. You are absolutely right. For the visceral pain also, you can start DRG because the DRG is the final ending point for both visceral afferent and somatic afferent. See, the visceral afferent comes from the periphery, it goes to the white rami, all those things, and then and then it lumbar sympathetic chain, then it goes to the ganglion, then finally it goes to the DRG. Somatic nervous system directly comes to the dorsal root ganglion, but the visceral afferents will initially go to the white rami, and from there it comes to the dorsal root ganglion. So ultimately, the visceral pain relates in dorsal root ganglion, and always, I'll tell you one more thing. It is better to target DRG in visceral pain because the somatic pain, the somatic nervous system from somatic nervous system and the visceral nervous system will have a crosstalk at the particular DRG level. So you treat only the sympathetic ganglion, not taking care of your DRG. Sometimes, the pain may still persist.
Yes.
Because of the somatic component persisting, visceral component blocked. Because there will be always a crosstalk between the somatic nervous system and the visceral nervous system at the DRG. Because the visceral afferent also goes via DRG. And there
Sir,
the crosstalk happens.
what are your machine settings for it, sir?
The machine settings is like in lumbar DRGs, I told you, I initially started doing 42 only. I mean, 45 volts only, but now off late I am doing 80 volts for even lumbar DRGs. And 12 minutes RFA, pulsed RFA.
Okay, sir. Okay.
And off late I started doing pulsed RFA for even lumbar discogenic radicular pain.
Okay, sir.
There you can put steroid after your pulsed RFA.
This I have been doing since years, sir.
Which is a very good result. I was only doing steroid, but off late I started doing pulsed RFA with steroid, and I see it's good. I don't know which is helping because my previous only steroid technique, transforaminal triamcinolone, was giving very good relief, and this is also giving a good relief. I don't know which is helping, but I started doing pulsed RFA.
Sir.
So can I ask you a
Happy
question?
two more questions in the
Anand sir, thank you. Recently, I've done one case of post TKR 2 years since she's been having burning sensation all throughout the joint, and then I've given 2 diagnostic blocks. In fact, generally I give only 1 diagnostic block, but for this patient, we wanted to reconfirm. So just above the medial collateral ligament, as you were saying, I just gave about 10 ml, targeting the infrapatellar branch, and then I've done a PRF. She was very, very happy. In fact, she also had this fixed deformity, that fixed flexion deformity. And after this, that also has, that angle has improved much better. I'm happy someone seconded the same. Thank you, sir.
Very nice. Congratulations. And that particular nerve is anatomically very distinct. And it is not a blind block anymore. Infrapatellar branch of saphenous nerve, you can actually make out. I gave one of the slide I mentioned where to scan, right? So make one mark one point at the inferior pole of patella, and down one mark it at the tibial plateau. 4 finger breaths laterally, make one parallel line and start scanning from lateral to medial and see the nerve above the medial collateral ligament. It will be in a nice facial sleeve. It's a hyperechoic nerve.
I got this pic from one of your students, and I did the same. In fact, I'll post it in the group also. I've seen that nice dot. I could see that. I've taken a pic of it.
It will be like your LFCN. Like
yeah,
you see
just before
LFCN.
it could branch out. Just before it could branch out, that nice dot I could see. Yeah.
Yeah, you can do a pulsed RFA comfortably.
I've done, sir. I've done a pulsed RFA after the 2 diagnostic blocks. I've done a pulsed PRF.
Yeah, it is like you can include this even in your genicular nerve RFA targets for your routine osteoarthritis need innervation.
Sir,
you include that.
If the distance from your needle to skin is more than 1 centimeter, you can do conventional RFA as well, sir. And I am doing conventional RFA if the distance is more.
Yeah, you can do because patient to patient, but this is one particular nerve very superficial. But if you in ultrasound, if you can measure the distance, I mean, if it is more than 1 centimeter, you can do a thermal. Definitely, yes. Why I told no need, because that is only a fat plane. Above the ligament, there is no muscle. And you even though it is 1 centimeter, the fat necrosis happens. That fat necrosis may be aesthetically not good. That is why I don't suggest conventional RFA for infrapatellar branch.
Sir.
Anandana, this is Dr. Murli.
Murli, how are you?
Fine, Anna, fine. It's a
good
nice
to see you.
Anna. Yeah.
Thank you so much. Good you have joined.
Anna, I have one doubt regarding post-herpetic neuralgia.
Yes, please.
Like how much voltage you are keeping for these patients, and how long, how much duration you are attempting this pulse RFA?
Post-herpetic neuralgia, 12 minutes, 90
Okay.
voltage. 90
Okay.
90 voltage is very simple. How to actually, I totally forgot. Today I thought I will take a short video of my machine. I have an Halyard latest generation. How
Hmm.
to choose the high voltage, what are all the settings you have to do. I totally forgot. Maybe next meeting I will show that. Very simple. You go to pulsed RFA mode and you
Hmm.
choose the frequency as 5 frequency. Okay, 5 hertz. So what happened?
Okay.
It will increase the voltage from 45, I mean, generally it is 45 volt to 50 volt, it ablates 42-degree temperature.
Correct.
But at the higher frequency, it slowly start rising. 45, 50, it goes up to 80, up to sometimes 90. Okay, it doesn't matter. Even if it goes up to 90, it gives a very, very good neuromodulation of the dorsal root ganglia of your post-herpetic neuralgia. I am telling you, my experience with post-herpetic neuralgia is plenty. I have treated a lot of trigeminal neuralgias and PHNs. PHN is one
Okay.
of the very difficult entity to treat. In many forms,
Hmm.
people say like pulsed RFA of a DRG doesn't help. I agree. Previously, it was the same with me. The
Hmm.
PHN is a very difficult entity to treat. But try this high voltage method. Again, one more clinical pearl in post-herpetic neuralgia is the results are better. The papers are telling, the literature is telling. Try attempting, do the pulsed RFA as early as possible. The days are gone, like where you say we have to wait. Actually, when you do it at the subacute stage, the results are
Okay.
better than the chronic stage. What is subacute stage? So, anything more than 3 months is called chronic, right? That is what our chronic pain says.
Within 3 months. Yeah.
Sir,
Within
1 month
three
is
months, actually, ideal time is the best
1
result you
month.
will get between 1 month to 3 months.
Exactly.
That
Hmm.
is called subacute stage where the results of PHN is better. The more it
Correct.
becomes chronic, the pathophysiology becomes more complex, more the signaling happens, more central sensitization happens, then it becomes the neuroplasticity is severe. Then the neuropathic pain becomes noxiplastic pain.
Yeah. Yeah.
Once it
Exactly.
becomes
Hmm.
noxiplastic pain, none of the procedure works. Go
Hmm.
to
Hmm.
cannabis. That helps.
We are waiting for that for next talk. Your favorite cannabis.
Cannabis is one of the beautiful invention in pain management. I'm using minimum 3 patients every day.
Nice. Nice. We
sir,
learn
your
from
next
you.
talk is on cannabis, sir.
Yeah.
Yeah,
Next we'll
all
have a thorough discussion on cannabis because now the indications are extending too much. And lot of complex pain conditions, cannabis are helping me.
Sir.
Especially in some clinical dilemmas, it helps.
Hmm.
Anand sir, I wanted to ask you, sir, if we get a patient post-herpetic neuralgia after 1.5 year, you recommend just giving cannabis or trying some pulsed RF modality
Try
first?
pulsed RFA. There is no harm in trying, but tell the patient it is 50-50. Be
Okay.
honest with the patient. That is very important.
So we do pulsed RF and we can give cannabis together. Maybe the combination should
Yeah.
do.
See, for example, today I gave one patient already one left eye enucleated. Okay, left side enucleation has been done. For the patient is ANA, NCA positive patient, and the patient developed SLE as well as the vaginous granulomatosis. It's an autoimmune condition, you all know, ANCA positive, ANA positive. Because of the vaginous granulomatosis, they have to enucleate the eye because patient become blind. Post enucleation, patient develops severe ophthalmic neuralgia. Okay. So what has happened? One of the pain specialists outside, he has done a sphenopalatine RFA. Post sphenopalatine RFA, pain has increased by 10 folds. Pain has increased by 10 folds. So today what I did that patient, straight away started on cannabis. Cannabis 1:2 THC. That's what in the next talk I will tell you about the dosing of the cannabis. I started on neuropathic drugs along with cannabis. The neuropathic drugs also I started on gabapentin, I started on lacosamide, I started on tryptomer. Along with that, I put that patient on cannabis because this is very, very severe. It's like it's a post-enucleated. We don't know whether it is a phantom pain. It could be a phantom pain because eye is removed and so much of neural structures got severed. So and it is a post sphenopalatine conventional RFA. So we don't know whether it could be a deafferentation pain or the neuritis secondary to a conventional RFA of sphenopalatine. So it's a very, very complex situation. It's a clinical dilemma where your cannabis will save you because it's a neuropathic pain.
Sir, for shoulder, cool radio frequency proves to be more better than the pulse radio frequency. So,
See,
in that,
for
is there
joint
any?
denervation, it's a different ball game, doctor. See, there are the joint denervation, you don't mix it up with pulsed RFA because it's an articular branch. When you are choosing an articular branch, always try to choose a bigger lesion. Okay, where the lesioning size is much more important. We are talking about the pulse radio frequency in spine. We are talking about pulse radio frequency in mixed nerves. We have so many. But joint innervation, you go, no, they are all articular branches. They are neither sensory nor motor. They are articular. For articular branches, there is so much of anatomical variation. The idea is to create a bigger lesion. Thereby, you have to capture the articular nerves. Those situations, cooled RFA is definitely better. Cooled RFA, I'm doing only for shoulder and knee RFA and sometimes hip. Rest everything pulsed. For peripheral now pulsed. For dorsal root ganglion pulsed. Thoracic and lumbar DRG is pulsed. Suprascapular pulse. I enumerated the indications, right? In that, there was no articular branch.
Sir, in that there was no articular branch. Is there any studies correlating a higher frequency pulse to overcooled in shoulder denervation?
Yeah, there are studies. They say it is comparable. Very interesting.
Okay. You have any experience of comparing, sir?
I have not done, but I know I have read the papers. Even the pulse radio frequency has got a very same effect like a cooled RFA. Papers are there. People have compared pulsed RFA with cooled RFA for knee genicular RFA ablation. And it is comparable.
Okay, sir.
So again, the target matters a lot. Maybe you would have captured the target rightly. That's why pulsed RFA has helped, even though the lesion is smaller.
Okay, sir. Okay. Will you try, sir? Will you try over?
I don't want to try because why I'll tell you to be very honest with you. See, all this joint denervation, no, one chance. Okay, it is one chance. So better to give the first chance as the best chance. Sometimes if it fails, patient will not come to you. If the if your first intervention fails, patient will never come to you. And the knee is a very complex joint, okay, and we are talking about 6 targets. Previously, it was only 3. Now it is 6. Now a lot of things are coming more and more with knee anatomy, updating the knee the articular branches. So I don't want to really try pulse RFA in knee genicular nerves. Because like I want to give a best shot to the patient. So the best shot is always cooled RFA because it has got 5 times bigger lesions than the conventional.
Sir, this doubt arose me because we had one ILD patient whose oxygen demand is increasing and is in carbon dioxide retention. He had adhesive capsulitis of the right shoulder, and for 6 months he tried conservative. He didn't respond. So then we did a pulse radio frequency of shoulder. His response was 50-50. So by your talk on higher frequency, I was thinking that if I had done a higher frequency, pulse radio frequency for his shoulder, because for him CRFA is not an option now because of his requirement of oxygen and advanced stage of ILD.
No, the requirement of oxygen and doing a conventional RFA of suprascapular now, there is no correlation. However, conventional RFA of suprascapular now will affect the oxygen requirement of the patient. That is a different entity. Say here the discussion. No, the oxygen requirement is because of the lung disease. Okay, your suprascapular RFA is not going to affect the vital capacity of the lung. Why we are not doing conventional RFA for suprascapular now? It's a mixed now. It can cause the rotator cuff weakness, and then thereby the dynamics, the mechanical dynamics of the shoulder is lost. If you are making the rotator cuff weak, they are the intrinsic stabilizers of the shoulder. If the intrinsic stabilizers of the shoulder is weak, the patient pain will go, but he will have difficulty in lifting the hand. He will have a difficulty in abduction, all those stuff. So that is the only problem with conventional RFA. With your interstitial lung disease, with your RFA, there is no correlation here. You are choosing
Sir,
pulse
not
therapy because you
conventional,
don't want
it's
emergency.
cooled.
Cool, do you want to do?
No, for for him the pulse didn't give him complete pain relief.
If you are doing cooled RFA, do cooled RFA for the articular branch. Again, for
Okay.
cooled RFA of articular branch and your lung interstitial lung disease, there is no correlation. You are not producing any pneumothorax. You are not ablating the phrenic nerve. See, the problem comes only when you ablate the phrenic nerve. When the phrenic nerve affects, then diaphragmatic palsy comes, then it affects the breathing. How your interstitial lung disease, diminished vital capacity, and your RFA technique of your shoulder is going to be correlated.
Sir,
Sir,
for
RFA will require
sedation is
sedation,
not.
Sedation for lung disease don't give sedation. If you are giving sedation, then of course it is wrong. It is
Because
difficult.
of that, we tried only pulsed rather than going for cooled.
You can do pulsed higher voltage. Whatever cooled radio frequency, it gives good result if your targets are correct. Ultimately, the target matters a lot. If your anatomy is good, if your imaging is good, if your needling is good, if your target is good, go for pulsed RFA high voltage. Extremely safe.
Okay, sir. Okay, next time I'll try for higher frequency, higher voltage.
Tomorrow I'm going to do a patient just in correlation, in continuation with your patient only. Tomorrow I'm doing one patient. Patient is having a pleural mesothelioma.
Okay, sir.
Patient is having a pleural mesothelioma with a diminished vital capacity. Patient room air oxygen saturation is only 85%. Patient is mildly tachypneic. But because of the pleural mesothelioma causing chest wall infiltration, patient is having a severe intercostal neuralgia involving 8th, 9th, and 10th dermatome. And because of the pain, our patient's work of breathing is further increased. I am going to do only a high voltage pulse radio frequency ablation of your 8th, 9th, and 10th intercostal nerves under local anesthesia.
Okay, so
There are a
frequency.
few more
what you are
questions.
going to-
Dr. Deepa, can you just hold on? There are a lot more questions in the chat box waiting, and we are running out of time. Sorry to interrupt.
Yeah, okay. Thank you.
Yeah, thank you so much, Dr. Deepa. Sir, Dr. Farhana Attar has asked clinical outcomes of pulsed radio frequency of genicular nerves as a part of rehabilitation for TKR surgery. Your observation.
Nowadays, people are doing cooled radio frequency ablation along with the TKR, if patient can afford. But you can do a pulsed RFA also. I see one orthopedic surgeon routinely does cooled RFA and then he continues with TKR. He first to do a cooled RFA and then he continues with knee replacement. What is the logic here? The logic is only is rehabilitation. Second thing is anticipating the post-knee arthroplasty neuropathic pain. So he is doing preemptively. He is publishing that. Do cooled RFA of 3 targets, so-called the T, supromedial, supralateral, infra, not 6 targets, 3. Our routine targets, previous targets, conventional targets. Finish that. I am talking cooled RFA. And then he is proceeding with TKR. Same knee. This is also happening. So you can do a pulsed RFA.
He's publishing on that case.
Yes. Because his endpoints are neurorehabilitation, the post-op rehabilitation is better. And then he can stop the post-op. Because according to him, the post-knee arthroplasty neuropathic pain is 20% incidence.
Yes, sir.
So you don't want that.
Hello, sir. Dr. Farhana here, sir.
Hi, Farhana.
Hello, sir. My question was because, sir, if the patient is not ready to go ahead with the surgery right now, he wants some time, or the orthopedic surgeon wants to rehabilitate the patient. They want some sort of movement, some sort of quadricep strengthening and all before surgery also, because the outcome after surgery is going to be good. That is what they say. So for that patient's PRF of this genicular nerve, as you said, high voltage, longer duration, what do you think? How would it respond, sir?
See, my honest, if any orthopedic surgeon in this particular talk, please don't mistake me. I'm going to come with one harsh statement here. If an orthopedic surgeon don't want to operate that patient, he has got no business to call you and do it. Ask him to send that patient to you, and you do a cooled RFA for that patient. That's all. You are not here to do a pulsed RFA to the patient just for him to rehabilitate. Because the genicular RFA for the patient is one of the proposed treatment modality for the knee osteoarthritis pain, where you are the primary treating doctor for that patient. Ask him to refer that patient to you and you manage the patient's pain. If patient's pain is relieved with your conventional RFA, tell the patient no need for TKR.
Yes, sir. That is anyways the dictum, anyways what we follow.
No, we
But
have to
at this
move away
time,
from all these things. I'm telling you, Farhana. We
yes,
have to
sir.
move away from all these things because what we are doing, we know what we are doing. And we
Yes.
have got evidence. Correct. And when we are giving an option of genicular RFA for the patient to relieve the pain, you can tell the patient, no, why TKR? If the patient's pain is gone, he's walking, why he needs TKR?
Exactly, sir.
You do prehabilitation, you treat the patient is yours. That's all.
Yes, yes, sir.
I will tell the patient, you send it to me, I will take care.
Yes, sir.
That's all. In fact, in my practice, a lot of knee osteoarthritis are coming to me now directly.
Yes, sir.
And for initial grades, I am doing the mesenchymal stem cells along with RFA. And higher grades, if the patient is willing for grade 4, I suggest TKR. If they are not willing for TKR, I will not do a mesenchymal stem cells. I only do a knee RFA, cooled RFA. Or if the patient is unfit for knee replacement, I will upfront tell them no TKR, go for knee denervation. But never ever promise a grade 4 patient that knee replacement is not a choice. There is a certain difference here. That is how people are getting into trouble. People are getting into trouble because they say even in grade 4 osteoarthritis, they say knee replacement is not an option. Knee replacement is the choice for higher grade of knee arthritis. But what about the subset of patients who are unfit for TKR, who doesn't want TKR? They are your patients. You go ahead and then do a knee denervation.
Exactly, sir.
There are a few more questions on similar lines, sir. Post knee replacement, genicular nerve block won't work, sir. The question by Dr. Nandishwara, DK.
Post
replacement, does the genicular nerve block work or doesn't work? Post replacement.
Actually, genicular nerve is not existing. Because you put implant, you cut it, everything, all those things. No. The post knee replacement pain is a neuropathic pain. It is not a noxicity pain. Mostly. So where you do only infrapatellar saphenous branch, that's all. Because when they are doing the knee replacement, no, anyway they cut the genicular nerve. So there is no nerve there to go and then do ablation. But the saphenous nerve is intact. They don't disturb the incision will not come there. That is how they get into a neuropathic pain due to saphenous nerve neuralgia, and thereby you do only infrapatellar branch of saphenous nerve pulsed RFA. It's very difficult. That genicular nerve RFA of post TKA, I am also done. But to me, looks like the saphenous nerve RFA has helped more than your genicular nerve RFA because there is no anatomy there basically.
That has effectively answered Dr. Sumit K. Singh's question also, sir. And then
Because that newer targets, newer targets. Actually speaking, our conventional targets are not supramedial and supralateral. They are medial and lateral branch of vastus intermedialis. Your supramedial and supralateral genicular nerves are like just close to your abductor and adductor tubercle. Both the tubercles, they will cut it during your TKR. So you cannot ablate your genicular nerves in a TKR patients. The implant will be there.
Okay.
You can only do a saphenous nerve RFA.
Dr. S. Parveen Manu has asked, in CRPS, what do you prefer, sir?
CRPS is the evidence is very good for pulsed RFA of DRG. In fact, one of the very good evidences for pulsed RFA DRG is CRPS.
Okay.
In fact, the pulsed RFA DRG, CRPS pulsed RFA DRG has got better evidence than pulsed RFA DRG of PHN.
And then Farhana again with how do you go about with differentiation pain? Clinical tips.
No treatment. patient fate.
Parana.
Yes, sir. Is there some?
Cognitive behavioral therapy is the
Yes,
only treatment.
CVT.
yes,
You give that one. Even cannabis won't work for CRPS.
yes, sir.
Dr. Khyati Patel, again, do you do high voltage PRF for all indications, and how do you decide the duration of pulse radio frequency?
Duration, depending on the papers. Now, a lot of papers are coming with longer duration. 12 minutes. One paper comes with 15 minutes. There is one paper with 20 minutes. Keep minimum 12 minutes.
Yes.
I am nowadays giving minimum 12 minutes time for PRF. When I started doing it was 2 minutes, 120 seconds. Then I increased to 3 minutes. Then once I did 6 minutes. Now not less than 12 minutes.
Okay.
One CRPS patient I did 20 minutes.
Okay. 20 minutes, sir. Oh. So, Dr. Sri, Santosh Lakshmi again, what is the onset of action of PRF and...
You know what is the PRF time for ultra extended normothermic PRF? Take a guess. That ophthalmic neuralgia, I told you, no.
Yes,
That
sir.
ultra extended normothermic pulse radio frequency I was talking about 37 degree. You know what is the duration of the pulse RFA? 40 minutes.
40 minutes. Oh. We are fearing for 5 to 6 minutes also, sir. So it's 40 minutes. So to learn from this class, definitely it's an eye opener for majority of the pain practitioners here. Definitely your session, sir. Then
that is the only disadvantage, I think. So long duration of PRFA.
I give the needle to my fellow and I'll scrub out.
See,
Correct,
there
I
is
put
a
in the
definite.
needle, give it to the fellow and walk out. I'll go have a tea and come back.
If there is a definite
Dr. Milon
advantage,
is
you should not.
asking how much temperature can we use maximum?
No, it is 42-degree temperature is by default. You can't increase the temperature in pulsed RFA. You can only increase the voltage. See, that is why I told why 42 degree. Why 42 degrees? Because it is 480 microsecond gap you are giving between the pulses. Each pulse is 20 milliseconds and each pulse gap is 480 milliseconds.
480.
So it will not go 42. You increase the voltage, you are only increasing the electrical magnetic field. And then you are causing down regulation of microglial cells of your nervous system. And you are diminishing the neuroinflammation. So that is why we call that as a neuromodulation, where it is not neurodestruction. The temperature will never go more than 42 degrees.
Yes.
You cannot choose, first of all, temperature in pulsed, unlike your conventional.
Yes. Dr.
Sir,
E. Lenin Babu, sir, very nice talk, Dr. Anand. With
hello, sir.
respect to long
Sir,
duration
last question, sir. My question was not answered, sir. Thank you very much, sir. Dr. Santoshi here, sir. For the wonderful talk.
Santoshi, how are you?
Hi, sir. Fine, sir. Fine, sir. Thank you, sir. Sir, what is the exact onset of action after PRF and CRF? Because patients usually expect immediate treatment. Since few people charge, they charge huge amount for radio frequency, they expect immediate results. So what should we explain to the patient? And what is the actual duration of onset of action for the PRF and CRF and also the duration of action, sir?
This is actually the wonderful question. I really appreciate this question. I wanted somebody to ask this question. Actually speaking, regarding the onset of action, there is a glitch. The pulse takes little longer time to start acting. The neuromodulation effect will take some time. I was talking about the down regulation of microglial cells and that all those stuffs, it will take at least 2 weeks time.
Okay, sir.
Okay. But the pain will start coming down. See, the patient will definitely, in very next day, you ask them, they will tell my pain is still the same. But actually speaking, the pain will start coming down. But the actual neuromodulation effect will kick in after only at the second week.
Okay.
That is why you see in the paper, the vasco reduction will be statistically significant only after second week. Second week, fourth, in fact, the vasco reduction will be maximum at the fourth week or the sixth week. Then it continues for 9 months. So at the first week, the mass score reduction is be more or less the same and not statistically significant. So tell the patient that it will take 2 weeks time. Unlike conventional, immediately the pain will go away, but patient will have numbness and other side effects because of conventional.
Yes.
Sir, then
Fine, sir. Thank you very much, sir.
my,
Thank you.
my doubt is, sir, why not add a local anesthetic after doing the PRF or a steroid, at least for
No
that
use.
acute phase? No, for the acute phase, I'm saying, sir. Like for at least that few days till the time the PRF starts acting. If the
Local anesthetic will act only for few hours.
steroid, sir?
See, adding steroids with local anesthetic in DRG is got no role to play for CRPS condition.
Yes,
I
sir.
told you no. If you are doing the PRF for discogenic pain, discogenic radicular pain, then you give local your steroid because where the steroid is treating the cause there. It is the anti-inflammatory action will help the chemical inflammation happening at the disc bulge. But for CRPS, you are doing a pulsed RFA and you are giving local anesthetic and steroid, it doesn't make any difference. Because where the mechanism of action at which the pulse radiofrequency work is totally different. But your question is for the acute pain, that acute pain to subside. Okay, you give, but it will be very long lasting, short lasting because the CRPS it's very complex. Okay, I will tell you the other way around. Will you do, you have done, for example, if there is a CRPS of L4, L5 dermatome or like post-herpetic neuralgia, one patient involving that, for example, you take ninth dermatome, D9 dermatome, you are not doing pulsed RFA, you are only giving local anesthetic and steroid. How long it will act? Answer to my question.
Very short, sir.
How short? First of all, it will not work because the pathology is different. Enhanced amplified neurosignaling is a problem. I was talking in this talk, I talked about the pathophysiology also in few conditions. The amplification, the amplified neurosignaling at the DRG because of upregulation of your microglial cell is the pathology there in CRPS. You drop a local anesthetic there once, 2 hours, 3 hours. Steroid in what way it helps?
Yes, sir.
The steroid extending the local anesthetic action for how long? Maybe another, maybe 24 hours. So it is like a diagnostic block.
Yes, sir.
Diagnostic block will work for 1 hour. Maybe you add triamcinolone or dexamethasone, it will act for 24 hours. So that is why I don't give. Maybe like you want to make the patient happy on the same day of the procedure, you can give that.
Yes, sir.
Rather, I tell my patient the exact truth. Wait for 2 weeks. Don't expect the pain to come down today. Wait for 2 weeks. They'll be happy to go home with less pain. But after 2 weeks, they'll come and say, Doctor, my pain has decreased very well.
Yes, sir.
Or else, you know what happened? Next day, they'll call you and tell pain has come back very severe. Pain has come with vengeance, they will tell.
Exactly, sir. I had such a patient with CA buccal mucosa, and in our government hospital, the surgical oncologist referred me. So I had given a mandibular block USG guided, and we don't have the RF machine, so I happened to be only with the steroid. So patient appreciated it. He had very good relief, but immediately midnight he had severe pain. So surgeon was saying me the next day.
No,
So
they will
really,
next
I
day they
thought,
will tell. Actually, these are all my practical experience I am telling you. When you
yes,
are discharging
yes,
the patient, discharge the patient with less pain, and after 2 weeks, patient will have no pain or very less pain. Rather, you discharge the patient with no pain, and you get the phone call very next day that the pain score is 10 by 10.
yes, sir.
Yes, sir.
Yeah.
Thank you, sir. Thank you.
Sir,
Thank you,
Anand
sir.
sir.
Thanks.
Good evening,
Yeah.
sir. Good evening, sir. Sir, this
Good
is
evening.
Sumit,
Hi.
sir.
Sumit, how are you?
Hello. I am fine, sir. Sir, very nicely explained, sir. Sir, I just had one query. We had a patient post knee replacement, and the patient was coming to us for like 6 months. We did a cooled RFA, but as you told, cooled RFA is of no use in that patient. So should we go for that infrapatellar branch of saphenous nerve that patient we can go?
Both, you do both. Both cooled RFA as well as infrapatellar you do. I also do both, but I believe only the infrapatellar branch saphenous pulsed RFA is relieving the pain. But when they are coming to you, do both. Because that above the condyle, just above the implant, at the junction between your and at the mid shaft, do a cooled RFA of both supramedial, supralateral, and inframedial, and then infrapatellar branch of saphenous nerve pulsed RFA. Because you can't do a 6 lesioning here. So
but
vastus
these
intermedialis.
nerve you told will be cut during the transplant.
So that's what I'm coming there. So obviously you will be only doing a lesioning of your vastus intermedialis medial and lateral branches. That has got very less supply to the knee. So, but you do that also, even though it has got 5 to 10% knee supply, it's okay. Still you ablate it with infrapatellar branch of saphenous nerve. Because the post-TKA pain is more of a neuropathic, where it is because of the saphenous neuralgia.
Okay. Thank you so much, sir.
Thank you.
Thank you, Dr. Sumit. Just a couple of questions before we wind up the talk, sir. So, Dr. E. Lenin Babu, sir, has asked very nice talk, Dr. Anand. With respect to long duration of pulse radiofrequency, is there any specific target for sensory stimulation amplitude?
So, in the stimulation is the same. What is the question? Please come again.
With respect to long duration, is there any specific target for sensory stimulation amplitude?
Hello, Dr. Anand. Good evening. Very nice.
Oh, Dr. Lenin, Jipmar.
Yes. How are you?
Hello, hi, boss. How are you?
Doing good. It was a very nice talk. Thank you for listening to the beginning. No, basically, I wanted to ask about the long duration and the high frequency pulse torque. Do you do any specific thing like how close you want the needle to be close to the nerve when you are doing the stimulation? That's what I wanted to ask. Or is it the same for the usual thing?
You're not audible, sir.
Yes, not audible.
Now, hello?
Yes, sir. Now it's audible.
Oh, okay. So somewhere between 0.3 to 0.8, I'm very comfortable. Obviously, like when I'm not getting paresthesia above 0.8, not getting paresthesia above 0.8, I will not attempt lesioning, whether it is any lesioning, pulsed RFA or conventional. So I keep the range between 0.3 to 0.8. Less than 0.3 also I never attempt because it will be intraneural. So 0.3 to 0.8 would be my range. I accept it.
Okay, fantastic. Thank you. Thank you, Dr. Anand.
Thanks.
Thank you, sir. Sir, on final question, Dr. Shivkumar, role of pulse radiofrequency in peripheral nerves like sciatic nerve in cancer patients. How long the pain relief lasts?
Fantastic. Sciatic nerve pulse RFA, there are so many papers are there. You can do a pulse RFA of the but only in cancer. Again, we have to be very careful. There comes the relevant question what Dr. Lenin Babu asked. Because if it is a cancer where already the sciatic nerve is encased or the sciatic nerve is infiltrated and the patient's already developed a foot drop or a deficit, don't worry about stimulation. Even a 0.3, it's fine. Or 0.4, it is fine. But I don't think we can do a pulse RFA of a sciatic nerve for a non-malignant pathology. There is no condition exists. There is no condition, non-malignant condition where you attempt pulse RFA of the sciatic nerve. This situation comes only in cancer. There, either directly you can do a pulse RFA of the sciatic nerve between 0.3 to 0.8, you get the stimulus and go ahead and do it, or you do a DRG. I put my own paper, right? I showed my own paper published. You can do 3, 4, 5, S1, dorsal root ganglion pulse RF. That would be better because at the DRG, the microglial cells are very much concentrated. Even in the sciatic nerve, peripheral nerves, we have microglial cells. But you target DRG, it is densely packed. So where the neuromodulation is better if you do it at the DRG, but you can do at the sciatic nerve also. But never attempt sciatic nerve PRF for a non-malignant cause.
Okay. So just this one of those rare occasions where the discussion outlasted the original class. Thank you so much, Dr. Anand sir, for the very elaborate lecture on pulse radio frequency and also answering all the questions patiently over the past 1.5 hours. So at one point we crossed even 90 participants in the room, sir.
That's very
Yes. Good gathering.
Very good gathering, and I hope all of them got a bucket full of knowledge from you regarding the pulse radio frequency.
happy I shared my clinical acumen. I'll be more happy if people take these points and they practice, and that benefits many patients. Ultimately, that is the end point we all need after this class. So patients should be benefited. We have to give a very good patient outcome to our pain sufferers. So let's aim for that. And what I discussed here is my own clinical practice blended with the clinical evidence. So that's what I always do when I give a talk.
Thank you so much, sir. I sincerely thank Dr. Mohan Bhaskar sir, ISSP AP State President, for moderating this session. Sir, your final word.
Thank you. Thank you, sir. Thank you, sir.
Thank you, sir. Thank you. Thanks for the opportunity.
Thank
See you
you,
next time.
sir. Hopefully, we'll meet soon again.
Fine. Thank you. It's always a pleasure discussing the pain medicine. So we'll keep talking. Thanks, Praveen, for involving me and for inviting me. Thanks, Srikant.